In the next session, we will introduce Dr. Tianpeng Tai. Dr. Tianpeng Tai is the assistant professor from China Medical University of Taiwan. And now he is attending vision in China Medical University of Taiwan. He's a famous surgeon in cataract surgery and retina surgery. And let's welcome Dr. Tian.
Thank you, Dr. Tsai and Thomas. Let me first of all thank you for your very kind introduction. And good evening, ladies and gentlemen. I am very honored to give this speech at the TSCRS about the major of early onset monocular cataract in high myopia. I am Peng Tai Tian from the China Medical University Hospital. This is a 46-year-old male had a vitrectomy with a gas tamponade, and for retina detachment 2 years ago, and he lost follow-up due to the COVID-19 pandemic, and visit our clinic again for blurred vision in the affected eye. The ocular examination revealed the high myopia in both eyes. However, a portion of right eye myopia might be related to origin from the nuclear sclerosis. His visual acuity was only 0.1 in the surgery eye. He had the fair macro contour showed on the OCT. Before arranging the cataract surgery, we taken more some time to discuss about his visual test, which later he had less close work and do not read usually. The initial expectations of him indicate including removal of myopia in the cataract eye, and then undergo the myopia laser vision correction (LVC) in the fellow eye. So, may I ask two of our experts, Thomas and Dr. Xu, this scenario one, should place by myopia need to be correct also doing myopia LVC for the patient around the 45 years old. Dr. Xu?
Because of the patient have a RD history, so in such kind of patient, I won't choose laser vision correction for him, for her. In such kind of patient, I will use soft contact lens or maybe clear lens extraction for such kind of patients. Yeah, thank you.
How about Thomas?
If this patient chooses to do laser visual correction for his myopia and presbyopia, like LBV by Tsai solution, it's a micro monovision and enhance the spherical aberration. When you have cataract surgery years later, maybe 55 years old, he still need monofocal IOL with zero spherical design. That is a limitation for choosing IOL.
Okay, thank you. And in the scenario 2, are there any other refractive plannings for this patient, Dr. Xu?
Just mentioned, if the patient don't want to receive refractive surgery, he can use the gases and the soft contact lens RGPs, maybe a clear lens extraction for her. Thanks.
How about Thomas?
About this scenario, my default position is subcontinent lens because we can choose the subcontinent lens power according to our daily practice. If this patient prefer to do paperwork or using computer today, you can left about -2 diopter for near sight seeing. If this patient prefer to do outside working, like playing golf ball, you can leave left just myopia about 0.75 diopter.
Okay, thank you. And in scenario 3, and which type of IO will be suitable for the patient, and Dr. Xu?
See, the patient has astigmatisms. But however, the patient have retinal detachment, we can know the retinal function of these patients. So if I can choose, and I will use a toric monofocal IOL. But if the patient want to have a more larger range of vision, maybe EDOF IOL can be considered, such as Vivity. Thank you.
How about Thomas?
You can see this patient had with the rural astigmatism, and its regular astigmatism is a bow tie pattern. It's 1.4 diameter by CK at 3 millimeter. If you have a T2 toric IOL, it is readable to have about 0.75 diameter with the rural astigmatism. Our cornea shape will change over time. It will toward 0.3 diameter per decade at against the rural astigmatism direction. I think monofocal IOL is my first choice. If this patient's macular function is great, EDOF IOL is another choice. But we should remember that it can decrease some contrast sensitivity. Thank you.
Thank you. So we read the data of the PENACAN. The patient had a high order operation. The patient has a small high order of operation value. Therefore, is suited for the multifocal IOL. If I repeat again, if there is no RD history, but he had RD, so the multifocal is not suitable for this patient. Though the PENACAN is the HOA is very low value. And we check the cornea shape. He had a regular cornea topography level suit for the toric IOL. Then we evaluate the cornea spherical aberration. He also had a cornea spherical aberration, which revealed by the Z40, and therefore suited for a spherical IOL. So in the scenario 4, which is my #1 formula for calculation IOL power in the high axial lens, Dr. Xu.
Patients with high myopia usually choose Barré Universal 2 formula to calculate the IOL power. However, I will also consider other IOL formula to prevent the hyperopia surprise. Thank you.
Thomas.
Third generation formula have its limitations, such as SRKT formula. Its sweet area is K value between 42 to 46 diopter, and the axial length just between 23 to 26 millimeter. In this patient, if you want to use SRKT formula, you need to target myopia to avoid the hyperopia surprise. Modern formula like CAN formula, Data Super formula, Barré Universal 2 formula, or even RBF formula, they are data-driven and then use an AI to achieve precise result. Thank you.
Thank you. So in the study published at IJO, and we see the Barré 2, Barré Universal 2, render the losses of predator error compared with the SRKT, IGC Holiday, and Harvard Q. And this is another case series published at IJO, and they introduced a newer IO formula called the here radial basis function version 2. The precision is compared to the Barré 2, and the accuracy of the refractor prediction is independent of the axial length. Since we have no the IO master 700 in our hospital, I prefer PENACAN being built in the Barré formula for calculating IO power and the ASIS. Finally, we choose monofocal toric IO with mini monomedian for the patient. So 3 weeks after the cataract surgery, he had a little hyperopia and astigmatism. Although his visual acuity improves slowly, he was very satisfied while wearing contact lens in the other eye, non-surgical eye. This is the angel OCT. The angel OCT revealed later the RDI had a decreased superficial visual density than the fellow eye 2 years after the RD surgery. That might be a clue to explain the limitation of the visual improvement. So this is a conclusion. The actual lens measurement may become less reliable in high myopia. Here, REF2 and Barré2 may be more precise in high actual myopia patients. And always consider the patients and their performance as a whole and the way in which both eyes function together. Thank you.